Hello, I am Dr. Lawrence Smith, Dean of the Donald and Barbara Zucker School of Medicine at Hofstra, Northwell. Thank you for tuning in to Well Said. In a culture of community, scholarship, and innovation, the Zucker School of Medicine is dedicated to transforming students into doctors who will improve healthcare, inspire change, and better the lives of the people they serve. It is why we are pleased to collaborate with WRHU Radio Hofstra University to bring you a program committed to sharing expert discussion and insight on health and wellness topics important to you. Join us today and each week for a recommended dose of Well Said with your host, Dr. Ira Nash.
Hello, I'm Dr. Ira Nash. Welcome to Well Said. Today, we'll be discussing minimally invasive heart repair and how it's changing the way we treat a wide variety of heart diseases. My guest is my colleague, Dr. Bruce Rutkin. Dr. Rutkin is the System Director of the Structural Heart Disease Program at Northwell Health and an Assistant Professor of Cardiology at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. Bruce, welcome to Well Said.
Ira, thanks so much for having me. I really appreciate it. I love your program and I'm excited to be here with you today.
Oh, well, thanks for that. So first off, how have you been holding up during this incredible pandemic that we've all been living through?
Yeah, it's been, as everybody, the past 18 months has been an interesting and at times a difficult time. I would say that we're fortunate, and I'm sure you feel similarly, to work with incredible people and for a wonderful and supportive organization. So I'm incredibly thankful for that. We faced our challenges in what we do, having been put on hold for a period of time last year, but we got back up and running quite quickly, and now we've been treating patients continuously, for about the past year without interruption, thankfully. So hopefully that will continue, and we do still see some patients and talk to patients who express some concerns, even family members, about them coming into the hospital, and we do everything we can to reassure them that we're safe and protected, and thankfully as a staff vaccinated, and we really have not seen any interruption in care. So we're really thankful, because our greatest concern is just that we want to make sure that people who need therapies, whether cardiac or otherwise, that they're getting the treatment that they need in a timely fashion. So that's what we focused on most.
I'm really glad you brought that up, and I never want to miss an opportunity to plug the importance of vaccination. I feel incredibly strongly that that's the only way we're going to get out of the mess we're in. So thanks for giving me an opportunity to do that. And let's get into structural heart disease. So what is it that you and your team are treating, and what do you mean by structural heart disease?
Structural heart, in general, is really not something that, even when I was training just 15 years ago as an interventional cardiologist, there was really no subspecialty of structural heart. Some of these conditions were being treated, perhaps in different pockets, surgically or minimally invasively, but certainly not as a team approach as we see today. When patients ask what is structural heart disease, I try and explain it as any type of a defect or disorder of the heart structure. For instance, as we'll focus on today, specifically with respect to heart valves, although it doesn't just include heart valves, it can include, the walls between different chambers, many different aspects. But in general, structural heart problems can be congenital, or meaning the patient can have been born with the condition, or sometimes they can actually be secondary to other conditions that occur over the course of life, simply just aging or other diseases such as coronary artery disease that can result in wear and tear or other defects in the heart. So, that's a general definition. We'll focus, and our team is mostly focused on the treatment of valvular structural heart disease, which can be, leaky valves, they can be restricted or narrowed valves, and I'm sure we'll dive more into that deeper today.
Yeah, I hope we do. And just to distinguish it from other major buckets of heart disease, so we're not talking about heart rhythm disorders, we're not talking about the kinds of blockages in coronary arteries that cause heart attacks. We're talking about, as you say, something kind of mechanically wrong with the heart.
Yes, for sure, mechanical. And, we tell patients, I'll try and sometimes tell patients I'm a plumber, and if you need a pacemaker, you're going to go to one of our colleagues that's an electrician. And when we talk about some of these valvular problems, I'll tell patients that it's like the plumbing in an old house. Over time, it's just simply some of these valves, they get stiff, they lose some of their pliability, and they become, as I said, either leaky or stenotic, which is, restricted. So those are the things that we're mostly focused on here in structural heart here at Northwell.
Give us a sense of how common some of these problems are. If you want, we can restrict it just to the valvular issues, but are these rare, common? What do you think?
So these are certainly common conditions, and we see, many patients from the community that have a variety of these conditions. And I'll give you a little bit of sense of some of the prevalence of these conditions, when I say prevalence, we're referring to basically the total number of cases that exist of these conditions in, let's say, in our population in the United States at any one time. So the conditions we focus mostly on are, number one, aortic stenosis, and that's because that was really the first structural defect that we actually had a minimally invasive solution for, now going on about 10 years. Aortic stenosis, which is a narrowing of the aortic valve, meaning the leaflets have lost their ability to open up and they've become restricted. We'll dive more into that later, I'm sure, in terms of symptoms, but has a prevalence of about 1.5 million cases per year in the United States, and about 500,000 or 500,000 of those patients who carry a diagnosis of aortic stenosis actually meet criteria for severe stenosis. And then once you get older, this condition becomes even more prevalent. So if you look at it based on population age, the most recent statistics from 2020 suggest that in patients over the age of 75, about 3% carry a diagnosis of aortic stenosis. So certainly not uncommon.
So plenty of folks out there with this sort of substrate or condition. What are some of the other conditions that you and your team are attacking in these ways?
The other two, major ones that we've added most recently are treatment of leaky valves with various repair and replacement techniques. The first one to come around was the mitral, and really the order in which these technologies have evolved have probably correlated to the complexity of the structure. Not that any of them are not complex, but the aortic is probably the most approachable with these techniques, and then the mitral was next, and then finally now we're delving into the tricuspid. And just looking at the prevalence of some of those, even more so than aortic stenosis, mitral regurgitation or a leaky mitral valve affects about 4 million people in the United States at any one time. We're doing about 50,000 mitral valve surgeries in the United States per year, not our minimally invasive approach, but 50,000 cardiac surgeries per year. And if you look at the prevalence by age, similar to the aortic stenosis, as we get older, these conditions become more prevalent or more common. So if you look at mitral regurgitation or the leaky mitral valve, almost 10% of the population over the age of 75 carries a diagnosis of either moderate or severe mitral regurgitation. And finally, I'll just touch on tricuspid regurgitation, which is the most recent valvular defect that we've added to our capabilities of treating minimally invasively. Similar to the aortics, there's about 1.6 million patients that carry a diagnosis of moderate or severe tricuspid regurgitation in the United States at any one time. And the one thing I'll mention, in addition to the prevalence, is that if we look at the numbers of patients with these conditions that are actually being treated who meet criteria for treatment, whether based on their symptoms or the severity of the disease, we also know that there's a substantial gap in treatment of these patients, meaning there's many patients that probably warrant intervention that are not yet surfacing or coming across to us to be seen. So we're doing a lot to try and really educate the community. You're even seeing these days, and some patients will ask me about it, we're starting to see even some direct marketing to patients by some of the companies that are making these devices. Wow. You could probably have a whole other discussion on people's thoughts on that.
Let's not go there right now.
We are seeing some of those. I'm seeing some of those, whether in mailers or even on TV commercials. From my perspective, we're really doing a lot of work with the physicians in our community, trying to make sure that they're all, educated and up to speed on all of the different things that we offer. And the reality is, these technologies are evolving so quickly and so rapidly that it's almost impossible for all the docs in the community to keep abreast because things are moving so fast. I can barely keep up with it, and this is all that I do and live and breathe every day. So we do a lot of education in the community with the docs.
So I want to get one basic concept nailed down here as well, which is when some people hear minimally invasive, they think about a smaller incision in the chest or the cardiac surgeon using a robot to help assist in surgery. But you're talking about a completely different kind of approach to doing these kinds of repair procedures. So what's the common thread, so to speak, that defines in your world the nature of the procedures that you're doing?
I really appreciate that question because we find that a lot of patients come in to see us and have a broad spectrum of impressions and expectations of what they're being offered and what minimally invasive means or what cardiac surgery means. And it's something that we do often spend time clarifying with patients. And what we both obviously know is that minimally invasive, as you alluded to, can mean many different things depending on the, area and the types of procedures that you're talking about. So if it's open cardiac surgery, it could be robotic, it could be a smaller incision, it could be a traditional, down the middle type of incision. With us, what I really refer to it, or at least how I think of it, is any procedure that I can offer a patient that can fix a problem that traditionally would require a more invasive approach, such as traditional or open cardiac surgery. The other thing I spend time with patients is they'll come in and they'll say, I'm here for that non-invasive procedure to replace or to fix my valve. And I do spend some time that these are not non-invasive. I think some people kind of misinterpret minimally invasive as being non-invasive at all, and that's certainly not the case. These are still invasive procedures, but as you alluded to, with the things that we're doing to repair and replace most of the valves, we're talking about usually an access through an artery or a vein in the crease of the groin, down in what we call the femoral artery or the femoral vein, no cutting, no incision, performing a complete repair or valve replacement, often with literally one or two stitches just to close a small access site in the groin. So right. Really, that's my impression. Now, that being said, of course, there are exceptions. There are some cases where, and as you alluded to, we are working with a cardiac surgeon. I'm an interventional cardiologist, but this is really a team approach. And there are some patients for some of the new things we're doing that we may not be able to get where we need to get from the femoral artery or vein, and sometimes we do have to involve a small incision, for example, up in the chest beneath the clavicle to access an artery or a vein where it might be a little bit larger than in the crease of the groin.
Without getting crazy details here, I mean, it seems to me that the two things that distinguish what you're talking about from what we'll call traditional cardiac surgery are that you're not cutting into anybody's chest and you're not putting anybody on a heart-lung machine. You're doing this mostly, as you said, through accessing an artery or vein and using stuff that's on the end of a long catheter that's threaded up through the arteries of the body into the heart.
Absolutely correct. So, and even taking that a step further, we used to do most of these procedures using general anesthesia, and we're actually rarely doing that these days. We're doing about 90% of our patients with what we call conscious or moderate sedation. So I think when we talk minimally invasive, the expectation certainly on the patient side, and certainly our goal as physicians, is we're trying to offer these patients the least invasive, doing the least to them as possible. As we say in our business, less is more. So whether that means, as you said, not using a heart-lung machine, no cutting in the chest, not putting patients under general anesthesia, everything we do with these cases, and as we've evolved over time, is making them less and less intrusive upon the patient, whether it's lines, catheters, of the sort. That's really the goal.
Let's take a little deeper dive into the first major procedure of this sort, and the one that you have the most experience, which is what you alluded to before, the replacement of the aortic valve using a catheter instead of an open surgical approach. So you mentioned that you're mostly doing this for a condition called aortic stenosis, where the valve doesn't open that well. Tell us a little bit more about that procedure.
That's really the procedure that kind of gave rise to this entire field of structural heart intervention. The first procedure was performed in France in the early 2000s, in about 2004. And, basically there, what gave birth to this is that there were a large number of patients that had severe aortic stenosis, where they were symptomatic, but for one reason or another, whether it was their age or some other medical conditions, the feeling was that they were not ideal candidates for the traditional open heart surgical approach. And you can imagine any number of things, including that the patient themselves may not have been interested in having open heart surgery, perhaps at age 90, where these patients had no other treatment option. So that's what really gave rise to all of this, was a major unmet clinical need. Transcatheter aortic valve replacement or implantation, those are interchangeable terms, is the concept, as you alluded to, of essentially taking a valve that is made of a metallic alloy that makes it kind of flexible and crimpable, and putting it into a catheter, a long thin tube, and then on the inside of that valve, which is almost like a large stent, sewing on some leaflets that are made of either pig or cow parts. It's either porcine or bovine pericardial tissue. And then that catheter, the valve is placed into the catheter, it's threaded up to the heart from the femoral artery or the femoral vein, and it's actually inserted right inside of the diseased aortic valve and then released by one mechanism or another. And there are a few different valves and a few different companies that are currently making these devices that are approved for use in the United States. So that is the transcatheter aortic procedure that we've been doing for actually we did our first one here at North Shore in April of 2011, and we recently just surpassed our 2,000th treated patient here at Manhasset. As a system, we're doing these procedures in 4 different hospitals, and we've done almost 5,000 of these procedures collectively. Wow. So we're really one of the largest and most experienced health systems with this in the United States.
Look, obviously, nobody wants to have their chest opened up if they don't have to have it done. How does the safety and the efficacy of this catheter-based technique compare with the more traditional approach, which does involve opening up the chest, opening up the heart, putting somebody on a heart-lung machine, et cetera, et cetera?
So it's a great question, and it's one that we talk to patients about every day in terms of what are really the differences. What are the differences that you can expect from a perspective of symptomatic improvement, potential complications, recovery, etc. What we have found from doing all these procedures for a long time and doing many clinical trials where actually originally they were compared head-to-head with traditional cardiac surgery is that some of the things you can expect from the two are different and unique to the procedure. So, for example, the TAVI or the minimally invasive, we know that it's going to, as you said, we're not putting these patients under general anesthesia. We're not using the heart-lung machine. We're not making any incisions. As a result, what could you expect? That their recoveries are going to be quicker, that their length of stay in the hospital is going to be shorter. For example, 1 to 2 days with the minimally invasive versus about 3 to 5 days with traditional cardiac surgery. The risks of bleeding will be lower. No surprise. We're not cutting. We're not making an incision in the chest. The rates of requiring a blood transfusion will also therefore be lower. The rates of developing certain types of arrhythmias or electrical disturbances, which are not uncommon after any cardiac procedure, are markedly less with the minimally invasive than with traditional cardiac surgery. Now, in all fairness, I would be remiss if I didn't mention some of the advantages or potential things that cardiac surgery offers that may be superior, although I will say that as the technology with the minimally invasive catheter techniques has improved, many of these types of things have largely begun to disappear. So originally, there was a higher pacemaker rate in patients undergoing the minimally invasive, and it was due to the way that these catheter valves would interact with the patient's electrical system. The devices have been modified. We've learned how to implant them a little bit better to avoid any interaction with the electrical system, and I can tell you that at Northwell in 2020, the rate of needing a pacemaker with a TAVI was no different than the rate of needing a pacemaker with open heart surgery, and that's really mimicked what we're seeing around the country as we've gotten better. These new technologies get better, and our implant techniques also get better and evolve as we learn more. So I think those are the big ones. The other big one, a lot of patients will say, how soon can I get back to doing the things that I love? How soon can I get back to playing golf, right, or to biking or to hiking, any number of things. And clearly with these less invasive techniques, we are sending these patients home from the hospital, and within literally a couple of days of being home, they're back to enjoying those things. And I'll make one other point, just because you had opened with some talk about the pandemic, and I do think it's relevant to what we're doing. We're seeing a lot of patients who really can't tolerate or afford much downtime from any number of issues that they're dealing with personally and socially. So it could be running a business that they need to do, that they don't have other people who can cover for them, and they're concerned that if they were to have traditional surgery and be out for an extended period, there could be a significant economic burden to them. So they really want to know, can I get back to work and be running my company within days to a week? And the answer with this is yes. And sometimes it can even be caring for a parent. It could be a parent that has other medical conditions, and the child is the primary caregiver and says, listen, I cannot be out of commission for 2 weeks or in the hospital for a week because I have no one who can take care of my mom or my dad, when I'm out. So we also take into account not just the medical, but we also take into account, really a whole patient approach, shared decision making, and we really look at those things, and especially as it pertains to patients getting back to their normal routine as quickly as possible.
I can tell you, as a cardiologist who has sent any number of patients to have these procedures done, staying in the hospital for only 3 to 5 days is a very short period of time after major cardiac surgery. I feel like, 5 days is kind of the lower limit, and people aren't really back to themselves for weeks after a major traditional cardiac procedure. So a quicker recovery, clearly. But, obviously that would be great if the outcome in terms of the procedure itself is just as good. So how good is the repair that you can do versus the surgeon? And what about the durability of that good result?
Great question, and it's also something that a lot of patients will ask us about is the durability. And we always talk about the trade-offs of anything that's less invasive versus the durability of the outcome. And the answer, in full disclosure, is we have some data on this because we've been doing it for about a decade, but also we're still learning as well. So, based on the original clinical trials, we know that, which were randomized between cardiac surgery and the TAVI, we know that durability so far seems to be similar, but we're only out to about 5 to 8 years in terms of following those patients. And as I tell patients, we've got a 30-plus year experience with traditional cardiac surgery, 40 years of replacing aortic valves. So the surgeons, have very, very detailed data, in terms of what to expect of the lifespan of a bioprosthetic surgical valve. We just don't have that long-term follow-up yet in this area, but we are accumulating it rapidly. And what are we seeing? So far, at 5 to 8 years, we're seeing comparable durability between the two. We are seeing some patients that occasionally come back with what we call a premature failure or a degeneration of one of these TAVI valves, just like we see in surgical valves as well, but not commonly. So we're just starting to see some of those and learning how to treat those. As far as the repair, for example, the mitral repair, we're using the edge-to-edge repair device, which is not a replacement. We're actually participating here at Northwell in a randomized trial, randomizing patients to the repair with the new devices versus a traditional surgical repair, and that's going to give us some insight into the durability there. So, it's kind of the million-dollar question is how long do these last? So far, we're very, very pleased with what we've seen, but I think the big picture in the long term is yet to be written.
And in fairness, if you're talking about somebody who's 90 years old, that may be much less of an issue, right?
Yes, that's, a great point, which is when we first started this, that was the patient population that we were treating because those were the patients who were not considered candidates for traditional surgery. What has evolved over the past decade is because the outcomes have been so good and because the technologies continue to advance, we have been allowed, based on, FDA and CMS, to go into younger and healthier lower risk patient populations in the United States. So yes, to that point, we are now treating 60-year-old patients with aortic stenosis who would be considered fine candidates for traditional surgery or low-risk candidates for traditional surgery. And that's where this durability question really comes into play because we really have to plan how are we going to manage this patient over the course of their lifespan. So if they're 60 and we replace an aortic valve at 60 and their life expectancy is 30 years, potentially more. We have to figure out how are we going to get this patient from 60 to 90 plus in terms of what sequence of interventions are we going to perform. And that's a whole new area that we talk about, which we call lifetime management of the structural heart patient. And most surgeons, if you talk to them, will tell us, figure out how you can get this patient through the rest of their life with potentially 0 or 1 sternotomy, or basically none or 1 cardiac surgery. And it is likely in some of these younger patients, it may have to be a combination of procedures, both minimally invasive and potentially traditional cardiac surgery. Again, as we move into younger and younger patients, these are becoming more things that we talk about more frequently.
So it sounds like your approach here is to have a detailed conversation with a patient about their unique circumstances and kind of walk through all of these things, knowing that there's still going to be some uncertainty about how long things will last and, frankly, how the technology will continue to evolve.
Absolutely, and I think that's probably, I sense you were going in a segue kind of towards the heart team concept, which we kind of danced around a little bit earlier, but I didn't really dive into. But to that point, it's really about planning for the lifetime of the patient, and that's really where the team concept comes in, where when we see these patients, we have a multidisciplinary team discussion with myself as a cardiologist, a cardiac surgeon, an echocardiologist, the referring cardiologist, such as yourself when you've sent us patients, and and the patient themselves, and we're really trying to come up with a strategy that we tailor and really customize to that patient. The one kind of semi-unknown, which we talk about patients a lot, is the technologies are evolving so rapidly, so we're making decisions today, but we really don't know where things are going to be 5-10 years from now. So one of the things we try and balance out is, while we're trying to plan for the future, we also say, what do we think is the best fit for you right now with what we have to offer? And in some cases, we say we should probably go with that, and then we can certainly consider, 10 years down the line, if that valve needs to be repaired or replaced, who knows where the technology will be, because it's literally every 6 to 12 months there's been a breakthrough in structural where we're getting a new device or a new technology. So we're really trying to balance all of those things when we make these decisions as a team.
So that's really interesting, and it brings up another question, which is where you think the future of conventional cardiac surgery is going. As you and your colleagues become more and more capable of treating a wider range of problems in a broader range of patients, are you guys killing cardiac surgery?
If you talk to the cardiac surgeons, they'll probably tell you this was something similar that happened 10, 15 years ago when stents, became more popular, and how that affected, the volume of coronary bypass operation. There is no question that if you superimpose the curves of the number of minimally invasive valves that we're doing versus the number of traditional cardiac surgeries that are being done, they are crossing, and we're seeing the minimally invasive on the rise and the traditional surgical on the decline. That being said, there are absolutely a number of things that we do not have catheter-based solutions for, and we may never have catheter-based solutions for. So I think the tough part when it comes to the cardiac surgery is it is definitely decreasing, but it is not disappearing, nor should it. There will still be certain things that we will need open heart surgery for. I think the key and the thing that I worry about sometimes is, are the surgeons going to be trained in terms of doing, some of these things that will ultimately need to be done that could be quite complex, whether it's taking certain valves or certain devices out of patients and then performing traditional surgery. So, again, the story on this is also still being written, but I will tell you that, we all want there to be good, technically skilled cardiac surgeons around for us if and when we need things down the line. I think the key is continuing to work with them and bring them together with us in what we're doing. And in fact, we're seeing many cardiac surgeons training in these minimally invasive techniques so that they can kind of keep their hand in it, know what's going on, and also be able to fix should problems arise in the future. So our surgical colleagues will be here to stay, but it's going to be, in an evolving situation as we work with these patients.
Yeah, and I think you are on the vanguard of this newer kind of approach where the distinction between being a cardiac surgeon and being an interventional cardiologist is probably going to continue to blur, don't you think?
Agreed. It's interesting because, we bring different skill sets to the table. What I've noticed is we can certainly work well together. It would be difficult for me to do some of the things that the cardiac surgeons can do, just based on our training, although we are certainly able to train many cardiac surgeons doing some of the things that we can do. So I think we've developed kind of a mutual respect and appreciation for the skills, and I think this true team and collaborative approach kind of brings everything together, at the table. But yes, I agree that we probably even may see more of these hybrid type training programs in the future where cardiac surgeons are learning to cross-train to do some interventional techniques, and perhaps even some interventional cardiologists will be able to do some more surgical type techniques in the future.
And in terms of the range of conditions that you and your colleagues are going to be able to successfully approach, give us a brief glimpse into the future. Where do you think you're headed next?
There's so many things going on in this space right now. The valve disease that we've talked about is kind of, I think, really just the tip of the iceberg, even though we're literally a decade in and we've treated hundreds of thousands of patients in the United States with these techniques. I think that the best is yet to come, potentially. We're seeing us going into the space of congestive heart failure, so treating patients who have a weakening of the squeeze or of the pump function, and there's various techniques we can do to potentially cinch together, a dilated heart and basically decrease the size, which might help to improve the function or decrease a leaky valve as a result. We're seeing some of these devices being employed for repair of the aorta, so the biggest blood vessel in the body that connects to the heart, obviously, and patients who have aneurysms, which is an enlargement, or dissection, which could be a tear of the aorta, also which traditionally require open surgery. We're seeing a number of devices, what are called grafts and stent grafts, which are being deployed also from the femoral artery and vein to potentially tack up some of these other problems. So we're seeing tremendous growth in this area, and as I said, it's evolving quite rapidly, but it's a great space to keep a watch on.
All right, well, then we're going to have you back in the future to talk to us about the latest developments. In the meantime, Bruce, thanks so much for being with us today.
Thank you so much for having me. I really appreciate it.
My guest has been my colleague, Dr. Bruce Rutkin. He's the System Director of the Structural Heart Disease Program at Northwell Health and an Assistant Professor of Cardiology at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. For more information about this program and to find past episodes, please visit sites.hofstra.edu/wellsaid. You can also subscribe to our free podcast, available on Apple Podcasts, Stitcher, or wherever you get your podcasts. Our listeners are welcome to send comments, suggestions, and questions to wellsaid@hofstra.edu. Until next time, I'm Dr. Ira Nash, and that's Well Said.